welcome to this talk on avascular necrosis, an important and prognostically relevant diagnosis that requires pathologic examination. I want to leave you with this statement as we start, because we're going to circle back to this later on when we talk about what we know about AVN and what we've learned at the clinic. And that is that the usefulness and accuracy of a test is not dependent on how well it confirms a common entity, but moreover is related to how reliable it is in excluding that common identity and identifying underlying and potentially completely separate, less common conditions. That's going to be an important point we're going to come back to a little bit later. Now, let's just start out with the obvious. What is avascular necrosis? Well, avascular necrosis historically has gone by a number of different synonyms. That has included idiopathic primary necrosis, idiopathic segmental subchondral infarction, primary aseptic necrosis, and a much older term that we're referred to as Chandler's disease. Well, basically, when we talk about AVN from a pathologic perspective, we need to look at a few things that are usually grossly evident. And I want to bear in mind that the changes of avascular necrosis are generally only diagnostic as such when the pathology is fully developed. So early AVN and early infarction, just like it would in the heart in a postmortem examination, would have a lot of non-specific findings. It's only the fully developed one that we can recognize as AVN pathologically. What are those? Well, generally speaking, we're referring to a large area of subchondral necrosis, which grossly appears as kind of pale yellow, sharply demarcated from surrounding trabecular bone. And usually there is an overlying intact articular cartilage surface that has largely separated. So there may be a little cleft between it and the underlying subchondral bone. We'll talk about the fact that over time this cartilage can be lost, again, usually due to the deformities of the articular surface that occur when avascular necrosis occurs. But inevitably, if this is not corrected or treated, invariably all cases of AVN ultimately become end-stage degenerative joint disease, which can sometimes make the diagnosis of, or the predisposing diagnosis of AVN more difficult to actually confirm. So if we look at the histology of avascular necrosis, it largely mirrors what we saw grossly. That is, in this particular case, we see an intact but separated articular cartilage surface, which has at least attached to the very base of it some subchondral bone. And then we have this underlying area of fairly sharply demarcated osteonecrosis with some repair at the periphery. If we look at this at a little bit closer power, you can see the osteonecrosis, at least in this case, is most fully developed within the marrow. Those are where the earliest changes usually occur, which is completely necrotic, and the bone is shortly following behind that. I only make this point because at least until it becomes completely developed, you will still often see sometimes nuclei within the osteocytes. And again, over time, all the lacunae will become empty in the trabecular bone. But at least at the initial stages of AVN, it's the marrow that will show the changes that are most characteristic of avascular necrosis. I mentioned this earlier. As the avascular necrosis becomes more advanced, you may actually lose that detached articular cartilage surface, and you'll be left only with the underlying subchondral bone and marrow necrosis. And of course, over time, you can get fully developed degenerative joint disease. Here you can see near the actual weight-bearing surface, the articular cartilage is largely gone. The subchondral bone is thickened and sclerotic. Here at the more periphery, you've got this frayed, fibrillated articular cartilage. Areas away from the non-weight-bearing surface begin to form more or less osteophytes, this being the original articular surface of the femoral head, and this being a protuberant osteochondromal-like proliferation. Again, we refer to that as an osteophyte. So why is the diagnosis of AVN important to establish? Well, first, let's talk about the incidence and demographics. Number one, AVN is a relatively common entity affecting up to 30,000 patients annually in the United States. These patients are generally younger, not always, but generally younger. Between 30 to 50 years of age is where the majority of these cases occur. We know that the majority of cases are idiopathic. That is, we don't really know what causes AVN, but we do know there are some predisposing factors. Those are principally chronic steroid use and alcohol abuse, again, for reasons that are somewhat unclear, but other conditions, primary trauma, pregnancy, collagen vascular disease, etc., seem to predispose patients to the development of AVN. We also know that AVN can affect a variety of bones throughout the body, but the femoral head is by far the most commonly implicated. And I would say at the clinic, it's overwhelmingly the femoral head, although we rarely see this within the knees and in the humeral head as well. Etiology is unknown. It's interesting that, it's sort of worth at least bringing up that the reason the cartilage is largely preserved is because it receives its nutrition from the synovial fluid, whereas the underlying bone requires a vascular supply from the periosteum to actually bring in its nutrients. So anything that interrupts the blood supply will invariably affect the bone, but largely spare the articular cartilage, which explains why it remains viable early on and even partially detaches from the necrotic bone. We know the interruption of the blood supply is necessary to cause AVN, but how these predisposing factors cause it is still very much unclear. From a clinical standpoint, these patients generally have pain related to the joint affected. And I've mentioned this earlier, untreated, invariably, AVN leads to osteoarthritis DJD. We also know that there's an increased risk of contralateral involvement. That is, if you have it on one hip, you're at increased risk of developing in the opposite hip, and not just restricted to the contralateral hip, but also in other places as well. This risk can be as high as 50 to 60% in studies where there's been significant follow-up. Important because if a patient has a predisposing condition that led to AVN in that one hip, your hope is that you may be able to address things like chronic steroid use, for example, and reduce the risk of it developing elsewhere. So it's an important disease to actually recognize. There's some indication, particularly older studies, found a correlation between AVN and a worse survival of the hip prosthesis compared to osteoarthritis or degenerative joint disease. More recent studies have challenged that, but the problem with more recent studies is the fact that it's unclear whether they actually had confirmation, pathologic confirmation of AVN, or whether this was just simply related to clinical and radiologic diagnoses. And we'll talk about why that is potentially very problematic later. So AVN has some, very uncommon specific features that can strongly suggest a diagnosis of AVN. But overall, the constellation of findings are not absolutely specific. And that is, if you look over here at this AP of the hip, you'll see some variable amounts of sclerosis and lucency, sclerosis on both sides of the joint, including acetabular sclerosis. And in this tomogram, you see the so-called crescent sign, which is basically the separation of the subchondral bone from the underlying articular cartilage. And of course, if you're lucky enough to see these findings, that's strongly suggestive of avascular necrosis. I will tell you, in real life practice, seeing the crescent sign is relatively uncommon. Unfortunately, we also have a significant number of cases that end up more advanced. And this is an example of that, where the femoral head has largely collapsed, become very distorted. You also see areas of sclerosis and lucency mixed on both sides of the joint, and some severe joint space narrowing over here, and even osteophyte formation. So it's end-stage degenerative joint disease. And I will tell you, from a pathology standpoint, when I actually see these particular findings present, it can sometimes be difficult to establish the predisposing AVN in these cases. So the background of this, let me tell you a little bit of background about my interest in AVN and pathologic evaluation of arthroplasty specimens. Most of us who do bone and soft tissue pathology recognize that to make a living doing bone and soft tissue pathology, we're going to have to do more than just bone and soft tissue pathology. So a lot of us get involved in GI pathology, GYN pathology, or whatnot to support this interest. Um, the volume of cases being what it is at the Cleveland Clinic allows people like me an opportunity to focus solely on bone and soft tissue. And when you focus solely in this area, you begin to see trends you might not have recognized otherwise because you're on service every day seeing these specimens come in. And one of the things I noticed when I first joined the clinic in 2016 was I began to notice that many cases of AVN that I was actually seeing were not recognized, or at least according to the path report, were not recognized preoperatively as AVN. And at first I thought, well, maybe that's just related to a mistake on the surgical path requisition. So I went back and I looked at the operative report, and ultimately that led to looking at radiology reports and radiology. And what we found was no, actually the overwhelming majority of cases, what we were seeing on the path report was actually the preoperative diagnosis. So I wonder, what else are we not seeing on these arthroplasty specimens other than the incidental findings that we were aware of? Were there other discrepant diseases that were also not being recognized? So I sought to examine consecutive arthroplasty specimens looking for concordance with the clinical preoperative diagnosis. Now, this resulted in a much larger arthroplasty study looking at a variety of things. For the purposes of this discussion, we're going to focus on AVN. Now, before we go even further, I need to also tell you how we evaluate specimens, hip and knee arthroplasty, and I should also add humeral head arthroplasty specimens at the clinic. So at the top figures, you see basically a femoral head that's bivalved and then sectioned in the quadrants, which is a traditional way that we do this, looking for evidence of eburnation, articular cartilage loss, subchondral sclerosis, areas of subchondral necrosis, and for that matter, any abnormality, incidental neoplasms, which we will rarely see in these specimens as well. Similarly, we address in the bottom of the figure here knee arthroplasty. So you see the femoral condyles to the left and a tibial plateau on the right. We typically serially section these specimens, again, looking for significant pathology. Both specimens, and at the Cleveland Clinic, I would say it's between about 40 to 50% of the arthroplasty specimens that we receive also have some soft tissue. Generally, the joint capsule, synovium, and of course, if it's the knee, it will probably also include some meniscus as well. And we generally take sections of bone, and that's in one cassette, and we also take additional representative sections of soft tissue, again, describing them if there's any abnormality that we see grossly. And so we began this study looking at consecutive non-fractured. We did look at fractures. That's the topic of a different talk. But for the purpose of this study, we looked at 1,722 consecutive non-fracture hip arthroplasty specimens from 1,676 patients. And of course, this was because some of these patients had bilateral hip replacements. All of these were pathologically confirmed. The diagnosis was histologically evaluated. We compared the clinical diagnosis from the operative report, the radiological interpretations. We looked at the radiology as well, the clinical risk factors, and we compared all that to the final histologic diagnoses that we rendered. And for this study, again, we focused specifically on AVN and its separation from DJD. And of course, what did we find? Well, we published the results of our study recently in the American Journal of Clinical Pathology, and we found simply that accurate and reliable diagnosis of AVN requires pathologic examination, plain and simple. And we're going to go into more detail on this. I've broken this down so it's a little bit easier to read in the subsequent PowerPoint slides about the results of this particular study. But this is now available in the American Journal of Clinical Pathology. It came out in March, April of 2021. So what did we find? And this summarizes at least some of the raw data that we looked at. So when we looked at these 1,722 consecutive non-fracture hip arthroplasty specimens, 1,559 had a preoperative diagnosis of DJD, 163 had a preoperative diagnosis of AVN. Of those 1,559 cases of DJD, 4% turned out to be AVN. Of the 163 cases that were preoperatively thought to be AVN, 26 turned out to be DJD. So if we look at our totals over here, about 11% of the histologically confirmed diagnosis on these cases were actually AVN. 62 of those were not recognized preoperatively. So almost a third of our AVN cases were not recognized preoperatively. Now, it's important for me to tell you before we go on that we were not the first to recognize this discrepancy. So it's not related just simply to Cleveland Clinic cases. We're going to get into more detail on this. We were the first to really deep dive into what those cases actually represented. But it actually turns out that DiCarlo and Klein, both pathologists at the Hospital for Special Surgery, in a humongous, the largest arthroplasty study to date, also published in American Journal of Clinical Pathology about 7 years earlier, found similar results. Turns out that about 2.9% of their DJD cases actually turned out to be AVN. Remember, our figure was 4%. 19% of the AVN cases thought to be AVN actually represented DJD. Remember, ours was around 16%. What was interesting, though, was when you looked at their total AVN cases, more than half were not recognized preoperatively. Remember, ours was a little more conservative at 31%. So we're looking at, between the institutions, 31 to 51% of AVN cases are not recognized pathologically. Now, they didn't deep dive into what these cases actually represented. We did, and I think that's what makes our study unique. But it's important to point out we were not the first to show that discrepancy. So what other things did our data show? Well, if you look at the 62 AVN cases that were clinically thought to be osteoarthritis DJD, those 62 cases, 58 of them had plain films, and among those patients, 5 also had MRI. Only 2 of those radiology reports actually documented AVN, and they were on the plain film radiographs, not on the MRI. The MRIs actually misidentified these cases as well. If we looked at the 26 cases of DJD that were clinically thought to have AVN, all of those patients had plain film. 6 also had MRI, and 1 had CT. The radiology suggested AVN in 17 of those cases, and that was radiology that also included the 6 patients who had MRI. So just judging by this, and I should have mentioned this earlier, most preoperative workups for hip arthroplasty specimens only include plain film. It's only when there's a stronger suspicion of additional pathology do they bring MRI in. And although it's not a lot in this particular case, we didn't see any evidence that MRI actually helped provide a more accurate diagnosis. Of the 137 AVN cases in which there was complete concordance with the clinical findings, all but 1 had radiology report, and 128 correctly suggested diagnosis of AVN. And one of the things I should have brought up also earlier was the diagnosis of AVN is not solely based on the radiology report. So in some of these cases, the surgeon correctly identified these as AVN, even though the radiology report did not suggest that particular diagnosis. So it's a combination of findings that should be causing the orthopedic surgeon to to preoperatively render a diagnosis of AVN, and it's not just based on the radiology. Now, what was interesting about our findings was the bias that may have been involved with this. Was a radiologic diagnosis of AVN was more likely to be rendered among younger patients, because our younger patients were the ones that tended to have the concordance, right, compared with older patients. And this was statistically significant. But we also found a statistically significant correlation between patients who had known risk factors versus those who did not have known risk factors. Patients with known risk factors were more likely to be diagnosed correctly radiographically than those that lacked those risk factors. And by the way, while I'm thinking about it, about 51% of our cases of AVN were idiopathic, which means about 49% of those did have AVN risk factors. And that's fairly consistent with the literature. A slight majority of patients with AVN will lack those risk factors. And in our study, those were the ones most likely to be missed, along with older patients. So just to show you a few examples from our study, this was an example of a case that was called DJD, radiographically, but pathologically we confirmed AVN. And you can see his plain film radiograph shows the classic findings of DJD with joint space narrowing, acetabular sclerosis. Again, the types of irregular joint had some flattening present. But what we saw was classic AVN, separation of the overlying articular cartilage from the necrotic subchondral bone. And here you see essentially the tombstones of the fat that are basically indicative of osteonecrosis. And just to show you the opposite example, this was a case where the radiology suggested AVN and the pathology showed no evidence of osteonecrosis. Actually, interestingly, the plain film radiograph in this particular patient showed more classic features of more advanced DJD, even compared to what we last looked at. Very joint space narrowing present, sclerosis, acetabular sclerosis, as well as subchondral bone sclerosis of the femoral head, and even osteophyte formation present here. But in the MRI, there was some flattening and signal changes of the femoral head that caused this interpretation to be AVN. And of course, if we looked at pathology, we saw classic DJD with loss of articular cartilage, subchondral bone sclerosis, and here is osteophyte formation and no evidence of osteonecrosis whatsoever. So if we look at some other data of AVN and DJD cases relative to preoperative diagnosis and risk factors, there's some other interesting findings which we've already somewhat alluded to, but I want to give you the actual data. That is, if you looked over here, these were patients that had a correct preoperative diagnosis and correlated entirely with the pathology of AVN. There were 137 of those cases, 130 patients. Those patients had a mean age slightly younger than this cohort of 52 years. And you can see the breakdown. About 57% of those patients had either alcohol abuse recorded in the history or chronic steroid use recorded as well. 7 patients had bilateral disease. Our figures are a little bit less than you would expect, but bear in mind that we didn't follow these patients completely out. All we did was look within the time period of the study for these patients. So it's very likely that had we followed these patients out, a greater percentage would actually develop bilateral disease. All the patients with bilateral disease had either alcohol abuse or history of chronic steroid abuse. If you look at the patients who were incorrectly preoperatively diagnosed as AVN, those were 26 cases. 52% of those, a similar percentage as we saw up here, had evidence of either steroid use or alcohol abuse. They were slightly older. There was one 48-year-old female who had a history of chronic steroid use, and it was interesting that she was thought she had bilateral hip replacements within about a 4-month interval. Excuse me, and she was thought to have AVN on both those, even though we gave a histologic diagnosis of not AVN at all on the initial one. It was still thought she had AVN, and of course it was not confirmed in either hip. Of the patients, 62 patients who were incorrectly thought to have DJD that ultimately had AVN, a smaller proportion of those had either alcohol use or steroid. We're looking at 28% versus 57% up here. Did that bias contribute to the misinterpretation of AVN? The fact that they were thought not to have AVN, I think it probably did. At least statistically, it showed that both from the clinical and the radiographic side. There was one patient who was morbidly obese who had bilateral AVN, hip arthroplasties within 3 months of one another. And in this particular case, it was thought that he just had DJD, even though we confirmed AVN in both specimens. So I mentioned earlier that we were not the only study to actually show discrepancies in femoral heads. There have been a number of studies that have shown this. What's interesting to me is some of these early studies, which a lot of orthopedic surgeons have used to argue that examination of arthroplasty specimens were not necessary, didn't find quite as many as we did. But I will tell you that in most cases, they were examining far less numbers of arthroplasty specimens, and their pathologic descriptions were in some cases largely non-existent, and at least the detail to which how they examined them is unapparent. One of the more interesting studies I thought was a study by Medding et al., who concluded basically that there was very little need to examine a hip arthroplasty specimen. They only looked at 313 hip arthroplasties, and they did note as the most common discrepancy 16 cases with a preoperative diagnosis of DJD, but a final diagnosis of AVN. But the authors concluded that this was not considered important, so they didn't contact the patient directly, which I found astonishing because AVN should lead to a more thorough assessment and follow-up of that patient, noting the risk to the opposite hip. But these authors didn't consider that important. A more recent study didn't find any discrepant cases, but again, not very good detail on the pathologic examination of these specimens. If we look at the more recent studies, we've talked already about DeCarlo and Klein's huge hip arthroplasty study, 58 DJD cases preoperative diagnosis AVN, 212 AVN cases preoperatively diagnosed as DJD. A very recent study by Layfield from the University of Missouri in the Archives of Pathology Lab Medicine looked at 953 hip arthroplasties, and they recorded that 35 cases of osteoarthritis had a radiologic diagnosis of AVN. 25 cases of AVN had a radiologic diagnosis of osteoarthritis, and the authors mentioned that this would be the topic of a future study where they would look into these cases a little bit more. But this was the first mention of actually, before our study, of actually examination of the radiologic diagnosis, not just the clinical pre-op diagnosis. And of course, our study, which looked at non-fractured hip arthroplasty specimens, found 26 DJD cases with a pre-op of AVN and 62 cases of AVN with a preoperative diagnosis of DJD. So what are our conclusions from this study? Again, I told you this is part of a larger arthroplasty pathologic examination study, which doesn't include things like pseudogout and incidental neoplasms, amyloid, etc., which will be forthcoming. Just wanted to focus on AVN here. But what I think we can safely conclude is not just based on the Cleveland Clinic experience, but based on other institutions, particularly those that are more meticulously examining their femoral heads pathologically, is that accurate and reliable diagnosis of AVN requires pathologic examination, preferably histologic. I have been asked, what about gross examination? I mean, could we just section it? And it is true that in most cases, we do recognize this grossly. What we have found at the clinic is about 20 to 30% of our cases are missed at the gross table. And this may be due to a variety of factors, the experience of the pathology assistant or the resident or whatnot, but we don't pick up all of them grossly. And I want to say roughly my unpublished experiences is about 20 to 30% is missed. And we've seen this actually occur not just in femoral heads, but also in humeral heads as well. If you look at our experience and that of hospitals for special surgery, 30 to 50% of histologically confirmed AVN will not be recognized preoperatively. We know that radiology reports are helpful, and examining radiology is a must. And we're all taught this in bone and soft tissue pathology, but radiology reports alone can be misleading and can miss it because the findings are not entirely specific. And we know that AVN invariably leads to degenerative joint disease, and that finding can actually cloud the underlying AVN. We also know that between 3 to 4% of DJD and OA cases between us and hospital for special surgery actually represent AVN pathologically. And when you're doing as many arthroplasty specimens as we and they do, that turns out to be a lot of cases. If you look specifically at the cases that are missed, they tend to be older than 60 years of age, and these patients often, not always, it's not absolute, will not have the known risk factors, particularly alcohol abuse or chronic steroid use that we have typically associated with AVN. We also know that there is the potential to reduce the risk of AVN if we recognize this earlier. And at a minimum, even if you were to argue that okay, I could alter the behavioral change, they're still going to be AVN. Well, shouldn't you be following those patients more closely? I think the answer is absolutely yes, because we know that those patients have a substantially increased risk of developing AVN, not just in the contralateral hip, but in other bones elsewhere. The jury's still out on the prognosis following arthroplasty, and I think it's still out because we need studies that have pathologic confirmation of AVN before we start drawing conclusions that the older studies are inaccurate. And remember, the older studies suggested that patients with AVN had a worse survival of their prosthesis than patients who did not have AVN. And again, because I know that pathologic examination of femoral heads has been decreasing across the United States, I'm suspect about that new data. And finally, I want to make one other important, observation, and that is that uh, this is not about the skill of the radiologists and surgeons. A lot of people will assume that when we're presenting this data, we're saying, oh, the radiologists and surgeons are no good at making this diagnosis. Look, as a pathologist, I recognize that I am the final, I make the final conclusions on what that disease actually represents, because I have the advantage to everyone else of actually having the real tissue present. When we looked at our study, it's important to note that we found these discrepancies independent of the regional hospitals, independent of the radiologists making the interpretations, independent of the orthopedic surgeons who were excising these femoral heads. Had nothing to do with them. I think it simply relates to the notion that here at the Cleveland Clinic, we more meticulously examine these specimens, possibly more than other institutions do. We take we have an experienced group of pathologists who understand how to make these diagnoses, how to separate degenerative joint disease with focal osteonecrosis from true avascular necrosis, and I think this is what's led to these conclusions. So it shouldn't be, you should not assume that by making this that this in all relates to the skill of our highly skilled staff here, who I have the utmost respect for. And that brings me back to this point. DiCarlo and Klein made this point, because one of the arguments I've had people make about this is, well, actually, we do very well. Look, the majority of cases we're recognizing, and that's true, but the majority of cases represent degenerative joint disease. Again, I use the analogy of a pap smear. If I have 100 pap smears, the vast majority will be totally normal. I could guess and I would be right the vast majority of cases, but that's not why we do the pap smear. We do the pap smear to recognize those cases that are abnormal. So DiCarlo and Klein had this comment, which relates to my first point. Even though degenerative joint disease is by far the largest proportion of the reported cases, the information garnered from less frequently identified conditions provides the most useful information for assessing the accuracy of the clinical diagnosis. It's not the fact that we did so well recognizing the most common disease. So with that, I'll leave you with this thought of, and this is basically how I sometimes feel in pathology, is that I'm basically on a long path with an uncertain destination. Thank you again for joining me on this journey.